Dear friends, thanks for inviting me to share my thoughts about this topic that is ketoanalogues. But what are ketoanalogues? Ketoanalogues are precursors of the correspondent amino acids and they are converted by transamination. They get an amino acid group from urea to form the new amino acid, so they work as nitrogen scavengers, and this is important in CKD, where there is an excess of nitrogen. Usually, essential amino acids are given with keto together with ketoanalogues. And ketoanalogues are used in CKD patients associated to protein-restricted diets because although severe protein restriction has shown beneficial effects on surrogate markers of uremia, protein energy wasting syndrome and other forms of malnutrition limit these therapies. But are ketoanalogues really effective on CKD? The effects of ketoanalogues on chronic kidney disease deterioration have not yet been fully confirmed. This meta-analysis comprises 10 randomized controlled trials and 2 non-randomized controlled trials with a total of 951 patients. A restricted protein diet supplemented with ketoanalogues was found to significantly delay the progression of CKD, particularly in patients with an estimated GFR over 18 milliliters per minute per 1.73 square meters. No significant change in estimated GFR was found when comparing a very low protein diet and a low protein diet. In addition, compared with placebo, restriction in proteins supplemented with ketoanalogues did not cause malnutrition. Moreover, restriction in proteins with ketoanalogues significantly decreased phosphorus levels, increased calcium levels, and decreased parathyroid hormone. Ketoanalogues supplementation has also been associated with a better control of blood pressure. This interesting study, prospective, controlled with 114 patients, CKD stages 5 and 4, assigned to a very low protein diet supplemented with ketoanalogues or low protein diet or free diet, and followed for 6 months with a goal for blood pressure control of 130/80, and antihypertensive drugs could be adjusted to achieve this goal. As we can observe, very low protein diet achieved better control of blood pressure in the presence of a reduction of antihypertensive drugs and was associated with a decrease in sodium intake and also with a decrease in fractional excretion of sodium. The decrease of fractional excretion of sodium in the presence of a stable GFR raises the possibility of a correction of extracellular volume expansion. As the previous study, they also show a significant reduction on serum phosphate, parathyroid hormone, total cholesterol and triglycerides without any impact in nutritional status. Ketoanalogues have also been associated with modifications on gut microbiota in experimental studies. However, in humans, this effect is not as consistent. This elegant work from the Medicatur study compares the effects of free diet, very low protein diet, Mediterranean diet, and Mediterranean diet supplemented with ketoanalogues in microbiota composition, serum levels of uremic toxins, indoxyl and picrosyl sulfate, and intestinal permeability estimated by D-lactate levels. As you can see, both the changes on microbiota and intestinal permeability were more pronounced on a very low protein diets than in Mediterranean plus ketoanalogue diet or any other diet. Also, serum levels of the uremic toxins, because indoxyl and picrosyl sulfate were very much lower in the very low protein diet patients than any other diet. But what about hard endpoints? What about the effect of ketoanalogues on mortality and dialysis risk? This is an interesting study from a Taiwanese National Health Insurance Research Database that compares 165 patients with pre-dialysis CKD on a low protein diet with ketoanalogue supplementation and matched with another 165 patients with pre-dialysis CKD on a low protein diet without ketoanalogues. There was no significant difference in mortality between ketoanalogue user and non-user group. And surprisingly, ketoanalogue supplementation significantly increased long-term dialysis risk and combined outcome risk, that is, long-term dialysis and death. Ketoanalogue supplementation also increased long-term dialysis risk in the subgroup of predialysis patients with diabetes mellitus, but not in those without diabetes. However, the results in the diabetic population patients are somehow different. This is a nationwide cohort retrieved from the Taiwanese National Health Insurance Research Database to study the long-term impact of keto-analog supplementation in patients with DKD stage 5. The primary study endpoint was all-cause mortality, and the occurrence of permanent and major adverse cardiovascular events was also evaluated. All patients were followed for 5 years or until death. The prevalence of keto-analog usage in this cohort was 6.3%, and the 5-year all-cause mortality rate in the keto-analog users was lower than that in the non-users. In addition, the incidence of end-stage renal disease was also slightly lower among the keto-analog users. The occurrence of MACEs was lower, although the all-cause mortality was higher among patients older than 70 years, and the risk reduction seemed more prominent among older patients. And as conclusion, very low protein diets and low protein diets together with keto analogues seem to be beneficial in CKD stage 4 and 5 patients, with better control of blood pressure, a potential effect in preventing hyperparathyroidism, insulin resistance, and retention of uremic solids. They show a potential role in controlling volume expansion with salt intake avoidance as a possible mediator. They seem to modify microbiota in uremic patients and prevent intestinal permeability, though this effect seems to be more associated with the protein restriction than with keto analogues in itself. And they also seem to improve lipidic status, proteinuria, and uremia in CKD patients. There is also a possible non-linear effect along GFR with patients under 80 milliliters per minute without that potent effect in nephroprotection. Maybe that is too late to this diet and supplementation with keto analogues being effective in preventing end-stage renal disease. And we don't have results with keto analogues alone without protein restriction, so the effect of keto analogues alone is still quite uncertain. But we are still needing some hard endpoints in CKD patients and obtained from well-designed clinical trials. And that would be my final conclusion. Thank you very much.